Hello, this is one in the series of lectures by the Functional Movement and Fitness Corporation, otherwise known as C's Health. We have three categories of lectures, at least, and the first category is the primary lectures, which discuss why the field needs certain things. It needs to incorporate the kinetic chain, neurology, which includes neuromuscular control and neurosensory, uh, comorbid disease, integration with PT and fitness centers, and why it needs to be there needs to be MDs, internists, and family physicians actually specialty trained in this area. This is an area where there's a surgical discipline, orthopedics, which is the basis primarily of the physical exam, that lacks an internal medicine branch. And so we believe internists need to be trained in functional movements. And so those are our prime lectures. And then we have a series of specific topic lectures when patient cases come up, the many different causes of posterior lateral instability in the knee, or why the different kinds of shoulder dyskinesis. The term shoulder dyskinesis isn't describing one disorder, but this series focuses in on the functional movement exam, and we're looking at functional people's functional movement, walking, lifting their arm over their head, and identifying diagnostic features from it. It's very different from the functional movement screens. Those are very skilled individuals. I encourage people to look at the work they've done, but this is a different area. We're just dealing with the term functional movement has been around for 100 years, and we're dealing with functional movements, using them for diagnosis and restoring them. And today is one of a series on Gait, which is the most important functional movement, both from a diagnostic standpoint, but also in terms of what patients want returned. And we're focusing today on just the general concepts and on the foot contact. And these lectures are educational and not intended to manage individual patients. They are not a substitute for patients seeing healthcare professionals. Among the reasons our patients vary, and no brief presentation substitutes for formal training. My name is Mark Brzezinski. My background's on the web, and I've gone through this on earlier lectures. So our goal is to increase function with age, non-surgical injury restoration, injury prevention, and fitness. So again, the most important functional movement, both to the patient and in terms of diagnostics, is the walking gait. And when we do an exam, we look at functional movements first. We look at people coming in the room. We look at how they move. Um, we do include semi-functional movements like squats, and we put a lot of emphasis on the neurology, actually pure neurology. We look at the central nervous system first, because if you can't sequence, or you have problems with inhibitory functions in the brain itself, then you're going to struggle with these patients. And then finally, we do go to joint exams, but we're not just looking for surgical problems, we're looking for other problems. So, popliteus muscle, or arcuate ligament in the posterior lateral knee, instability of the knee from problems with the external rotators, or in the ankle posterior tibialis. So this is a very different approach. It's a much more functional approach to musculoskeletal disease. So when it comes to gait is extremely complex. You can learn so much about the patient from gait, yet it comes down to some very simple principles. Um, are impact forces being stored, particularly during mid-stance, for maximum propulsion endurance, and then released, or are they being transmitted inappropriately to bone, ligaments, and other structures leading to injury? And this is a critical concept, and also critical is if patients aren't using them efficiently, why do they have, why do they have inversion of the foot or supination? Why, when they do a single knee squat, do they does their knee come directly to the midline? So Gait gives you so much information. It can give you information about muscle strength and flexibility. And you see so many people do exams of the lower extremity with their arms. And the legs, the legs are so much more powerful than the arms. And yes, if you're really good, you can pick up, rate of activation and more subtle aspects. But you're not really going to test an Achilles, the Achilles tendon system with your hand. Not in somebody who's an athlete, for instance, or even in 65-year-old woman. It gives you an idea of the kinetic chain, and it gives you an idea of neurologic function, both motor, how it's being controlled. So if you had an injury to the common peroneal nerve or sciatic nerve that caused muscle dysfunction, like failed dorsiflexion, or sensory issues like proprioception, which is in particular proprioception, you can pick it up by watching the gait. And I love to use the example of B12 deficiency. I've diagnosed multiple times B12 deficiency by watching somebody walk. The same thing holds by ataxia. And the other point is, and this holds for a lot of aspects of the exam and symptoms, sometimes they're transitory. I personally have had workouts where I've hydrated and my hydration and electrolytes were off, and I had the exact symptoms of normal pressure hydrocephalus minor ataxia with a few other symptoms. Or we can get problem. I'll do a plyometric workout and the next day be teaching a class to students, and when you do a few knee bends, you can find your kneecap popping, patellofemoral syndrome. That's not really a disease, that's just fatigue. And so we have to differentiate those out too. But the first point is that, we're looking at the running gait, and the drawing on the left, the runner is actually landing on the front foot, which is an abnormal run. But you can see you're looking at the upper body too. And shoulder experts, actually, some of the best shoulder experts, start their exam by watching people walk, because how your gait is affects your shoulder complex. And so if we look at the woman on the left, if you look at her back leg, we know that we've got a pretty good idea, better than examining her lower extremities with our hands, that her extensor function and flexor function in her thigh is good. The Achilles tendon complex in that back foot is doing well. She's up on her toe, she's flexing well. So instead of using your hand, we can see this. And then if we look at her front foot, she's dorsiflexing very well. She does not have damage to her common peroneal, or if she had, sciatica, isn't affecting tibialis anterior or anterior tibialis, the dorsiflexors. So the dorsiflexors and plantar flexors are intact. And there's so many things you can pick up by watching somebody's gait. But when thinking about foot position, which is sort of the subject of this lecture, it's important to think about when we throw a baseball, a throw, a punch, do a golf swing, the energy is predominantly rotational. And yes, walking is translational, but the force is being generated to a large degree in the horizontal plane and not in the frontal plane. Translation is clearly forward, but we're generating force in the frontal plane. And it's best, at least from our perspective, to think about that you start an external rotation and then you move into mid stance into internal rotation where you absorb gravitational energy if you're doing it correctly, and then you release that on toe off as you go back to external rotation. And you could see that the body is built this way. It's a trick question, name the primary internal rotators at the leg, and there really are none. And the primary rotator is gravity and the structure of the skeletal system. It's designed under gravitational force to internally rotate. So we're looking at two different runners here. Generally in the field, you want to look from the back side and from the front. I don't necessarily think you gain a lot from the front, but when we look at the person on the left, she's actually looking at her right foot. So when we think about the stages of the foot, and this is from the basically what we've derived from the literature. First, when you're standing behind somebody with normal architecture at the hip, you should see roughly 2 toes from standing behind them. Their outer 2 toes. So there's a slight external rotation. When the foot comes down, it comes down slightly to the outside of the midline of the heel. You move more toward the center. As you could see, this runner is, and actually I think she's a little bit over pronated, but she serves the point. She's loaded her energy into the center of the foot, and then you take off on your big toe. And so we can think of the outside of the foot as being the solid foot. Actually, if you take one of those foot models, it's very interesting. They work out well. When you turn the foot outward, and so invert the foot, the cuboid bones lock. And when you turn the foot for eversion, they loosen up. So when you come down on mid stance, more toward the medial aspect of the foot, then what's happening is you're stretching structures like the plantar fascia, but you're also eccentrically contracting a lot of muscles, from the muscles of the Achilles tendon complex to the gluteal muscles, posterior tibialis, peroneus longus. And so these muscles are storing energy. If you come down and ride the outside of the foot at mid stance and you're on the solid portion on the outside on mid stance, then that energy is going straight up the skeletal system, leading to problems like stress fractures, back pain. Now you can obviously, in this woman, I think if we were watching the video, likely is a little bit overpronating, and that can cause problems too, including plantar fasciitis. But you want to load energy at this point because you're turning into it. So you're going from the outside of the heel and you're turning in to the arch and rotating in, but the rotation is all the way up into the hip. And then on toe off, you're turning back out again, releasing that energy. And so when we look at this from the side, really what we want to see, this is a very nicely done. The woman is a little bit short on the front leg. This is common on treadmills. You would have liked to have seen her stride a little bit longer, but by looking at her again, we can tell that the majority of her muscles in her legs are working well. And so, she doesn't have, if she had tight hamstrings, she dropped that foot earlier. And somebody who did this on the street, you would wonder a little bit about tight hamstrings, dropping that foot the way she is a little bit early. But likely it's just due to the treadmill. But uh, we can get an idea. I mean, her flexors. You look at it when you look at the flexors at the hip. You're looking at two different things. The flexors at the knee and with the quads at the knee function, and at the hip, iliopsoas, and the quads. Her body is straight up. She's not falling backwards because she doesn't have flexor strength at the hip, and also she's pulling that knee into position. She's holding it in position on heel contact, and so her flexor structure is doing well. Obviously, we're not looking at both legs, and she may have looked totally different on the opposite leg. But going back to the picture on the left, you can see why many people are opposed to shoes with too much padding in the back, or the minimalist approach. If you come too far on the outside, too far back, and on the outside, it's hard to get into that arch, and you end up riding along the outside of the foot. At least that's the theory behind it. And there are some people who struggle for other reasons, and for them, coming down in heel contact may not be ideal initially until you can figure out what their other underlying problem is. And sometimes you want a little bit more toward a midfoot strike than a heel strike. But I think that these slides have illustrated the general principles. So the other thing that is something that I see all the time, and you can't forget about the femoral neck and acetabulum. And as much as I'm known for developing an imaging technology, but most imaging, if you look for a problem, you're going to find something that's potentially surgical if you just blindly look. But the one area where I really would love to have imaging data on almost everybody who walks through the door is at the hip joint, because a significant number of patients are going to have issues with the femoral neck anteversion, or its posterior, or they can have it superior or inferior displaced. And there also can be issues with the position of the acetabulum. You can have an acetabulum that's pointed to laterally, for example. And so just turning the foot, telling the patient to realign their foot without knowing what's going on in their femoral neck can be dangerous. You can actually be pulling the femoral head outside of the acetabulum. So you have to do a complete exam. It comes down to knowing what you are doing, and Craig's tests is one of the examples. And I haven't seen a lot of data how actually sense the specificity and sensitivity of it is, but does give you some idea of the position of the femoral of the femur. So we're paranoid about Dunning-Kruger. I mean, so much at the time people get a little bit of information and they go out and they use the little bit of information correctly. And so we reserve teaching full exams, full courses for when we're actually with people and we can test them on it and make sure they understand how to use it in full. But but some sources, Newman's textbook, and we've licensed some image from it, is a very good textbook. Not just the Gait section, but the previous sections on hip, knee, and ankle. There's a podiatrist in New York City, Emily Spickler. Hopefully I pronounced that correctly. This is a YouTube video she does on an introduction to Gait. She also has some courses on Gait. And with all these sources, we may not agree exactly with what they're saying, but we're pretty much in the right, same ballpark. And this YouTube video, it's under the name Chad Snyder, and I'm not sure what school he's from, but the video is presented by a woman who I didn't find identified herself in the series of videos. But the videos themselves are very nice, in my opinion, and you might want to look through them, but you can search under his name. So these lectures are educational and not intended to manage individual patients. They are not a substitute for patients seeing healthcare professionals. Among the reasons our patients vary, and no brief presentation substitutes for formal training. Thank you very much for taking the time to listen to this lecture.